been asked to watch this video because of ligament instability in the knee. And we talked about in the anatomy video of what the ligaments are, and now let's specifically discuss all of them. The most commonly injured ligament in the knee is the MCL. It very often occurs during skiing, where a valgus force, meaning the lower leg, gets pushed out to the outside of your body, and the MCL is on the inside of your knee. And so that stretches the ligament or tears it completely. The majority of times, because the MCL is outside of the joint, it usually will heal. If it's a complete tear or associated with a dislocation of the knee, then we need to fix it. And we would either repair it primarily or we would use allograft to fix it. And I will discuss all those options with you in the office. But so the MCL is the number one injured ligament in the knee. Number two is the ACL. You all hear about anterior cruciate ligament reconstruction. We sometimes will treat it conservatively depending on what your activity level is. Not everyone needs an ACL, but if you want to have a stable knee, if you want to function in sporting activities, or you just don't want to have a loose knee, we can always take care of your ACL. The ACL reconstruction process is a surgical intervention. We can use your tissue or we can use cadaveric, dead person's tissue, to stabilize the ligament. And it really depends on what your activity level and what you're like. So if you're a young individual with an ACL tear, we usually would recommend getting it reconstructed. The problem with an ACL deficient knee is you have that instability. With every instability episode, you're impacting the cartilage of the tibia into the cartilage of the femur, and that will lead to more arthritis. So our goals in reconstruction are, number one, giving you a stable knee on which to function. Number two, decreasing your instability episodes, and also allowing you to play activities and decrease the arthritic changes that you would have moving forward. The way we reconstruct is multiple different grafts. The number one graft these days is the bone patellotendon bone. We take a little piece off your patella, the tendon in between, which is only a partial segment of the patellotendon, and then a piece off the tibia. And what we do is we reconstruct that with screws in your knee. Immediately post-operatively, we get you moving quickly, but we protect your weight bearing for several days. And so we'll discuss more of that if you do get the ACL reconstruction. Other graft options would include quadriceps tendon and hamstring tendon, as well as allograft. So you can choose and look at any graft type you want, and I will discuss all the pros and cons. The two most common reconstructions in the United States at this point in time are going to be bone patellotendon bone and hamstring grafts. Each one has some donor site morbidity, so you're taking something away from another part of the body to put into the knee. With the bone patellotendon bone graft, you get a little bit of increased anterior knee pain and sometimes patella baja. What that is that with the scarring, the patella gets shorter, and so you get a little bit more of that anterior knee pain. As far as the hamstring graft is concerned, you get a little bit of posterior thigh pain. So where we take the graft, we make a small incision in the front, but then we use a stripper to get the graft out, and that has to heal in with scar tissue. So it'll be a little tighter, a little stiffer, and some scar tissue associated with that. Quadriceps graft is above the kneecap. We take a part of the patella and then the quadriceps as well. That would be the third option that we would think about. As we get older, and I'm old, I would use allograft, cadaveric tissue. The reason for that is there's no donor site morbidity. You get no other problems associated with this, and it's a much quicker recovery as far as the surgical intervention is concerned. We have all the pre-op instructions and all the post-op physical therapy protocols on the website, so you can download them ahead of time, bring them in, and we can discuss all of the options as far as the ligament reconstruction for the ACL. The other three ligaments, the lateral collateral ligament, sometimes can get torn as well, especially as part of a knee dislocation. And so we would reconstruct that with allograft, where we take it, put it inside the femur, and we weave it through the fibula to give you that stability on the outside of the knee. The posterior cruciate ligament is less commonly operated on. It sometimes needs to be operated on depending on how unstable it is, especially with a dislocation episode. You would need to reconstruct that prior to reconstructing the ACL. The other ligament that commonly gets torn is called the MPFL, medial patellofemoral ligament. It is a stabilizing ligament that goes from the femur to the patella, and people that have tracking problems with the kneecap sometimes can dislocate that kneecap. If it does dislocate, once again, we treat with conservative modalities, strengthen the muscles around the knee to hold it in place better, but oftentimes we need to reconstruct that medial patellofemoral ligament. And that is to try and tether it in place, keep it in the groove so that it doesn't dislocate. Sometimes associated with that, depending on how bad the angle is, we sometimes need to move the tibial bone as well to get it in line so that the medial patellofemoral ligament graft will hold. Once again, if you have any questions about any of these in the office, feel free to ask us. This is just a general overview for you.